Welcome all. This session is going to be on the multi-society guidelines on SI joint pain and treatment. And so this is the efforts of a multi-society working group, and we're going to provide an overview for you today. We think that this work is really important given that CMS, and the inability for us to perform radiofrequency ablations at this time, but hopefully that this work will help us kind of fight against that and help be able to provide effective treatments for our patients. So first up, my esteemed panelists here is Dr. Enda Tescu from University of Chicago, Dr. Steve Goen from Northwestern, and David Parmezato, who's in private practice in Pennsylvania. And so we will begin.
I think I start. There you go. Thank you very much for coming. Yes, welcome. We're good. Thank you very much for coming. And, we'll present today the guidelines. I mean, a little bit of the guidelines. The guidelines have about 100 plus pages of evidence. So we're going to try to kind of go quickly through some of the highlights of this. It's been a very long and very wonderful collaboration between many physicians, many societies. And this is what the result is. I'm going to talk about epidemiology, diagnosis, and performance. My name is Magda Tescu. I work at the University of Chicago. Well, if I can move the slides over. Anyway, old style. These are my conflicts of interest. Nothing is relevant to this talk. A little bit about sacroiliac joint because I'm the first speaker, so I just really want to orient everyone about what we did and why we did it. It is a very complex structure with multiple pain generators, has a superior and dorsal portion, which is amphiarterial with cervical and iliac surfaces separated by fibrocartilage. An inferior portion and ventral portion, it's a diarthrodial, which has a hyaline cartilage, fibrous capsule, and synovial fluid. It is very difficult in diagnosing pain arising, particularly just from the sacroiliac joint. And there's discrepancy in prevalence. The only diagnostic test we have is injection of local anesthetic into the joint. Therefore, SI joint is a very complex structure. Injection for this and radiofrequency ablation for that have been used for many, many years, studied very long, but nothing comparing with the degree of detail and study we did with this complex guidelines, which involved about 30 academies and several societies contributing to it. These are the evaluation criteria we used for this document. We had used those criteria for other guidelines produced by ASTRA. Its level of certainty and a grade of information. So in terms of epidemiology, there are several questions. There are very many questions placed for those gradings, which we applied this grading system on. The ones which I'm going to talk about is first is going to be the epidemiology. What is the prevalence of SI joint in the individuals with low back pain? Turns out it's not very uncommon. It's about up to 30% of those patients which have low back pain have SI joint generated pain. So based on the available evidence, this is grade B with moderate level of certainty. However, if you have to decide which part of the joint is giving you pain, if you have to look for dorsal ligament-mediated pain, this is a grade insufficient evidence. So there is no evidence to support that there is a pain specifically coming from this area. In terms of lumbosacral spinal fusion, it's higher than the dorsal ligament, 30 up to 60% in some studies. And then the evidence is grade C with low level of certainty that it's coming from that area. Mechanism of pain for fusion surgery involves the adjacent segment stress, increasing loading and shear forces, acceleration degeneration, and some risk factors are involved into the contributing to the pain, violation of ligaments or synovial lining during iliac crest bone grafting from the surgery. In terms of diagnosis, the question we pose is, can history and physical exam identify a painful sacroiliac joint, and can history and physical distinguish articular sacroiliac joint pain from dorsal ligament pain? Now, in terms of history, we know locations, but it has some predictive value. We have some patterns for the SI joint pain, buttock pain, not past the knee, groin pain, and some characteristic of painful activities, some historical features such as trauma or some inflammation. In terms of physical examination, provocative tests, Faber, have been used, motions tests like Stork, and also we looked at the inter-rater reliability. How reliable are the joint mobility tests for identifying the SI joint pain? And what we found out is that for the historical components, history taking and physical exam, there is low quality of evidence that these would help predict intra-articular injection of SI joint. So we found out that this is grade B evidence with moderate level of certainty based on the available evidence we found in the literature. There is also little available data regarding the ability to predict results in patients with primarily extraarticular dorsal ligamentum pathology, which we found to be grade C evidence and moderate level of certainty. For individuals which we applied a cluster of tests, the specificity of those tests, it's lower than the sensitivity, with negative tests have a higher predictive value than positive tests with a grade A high level of certainty. And the reliability of SI joint provocation, especially Patrick test, grade C evidence with low level of certainty. In other words, historical variables and physical exam signs can be used to select patients for diagnostic injections, and we found out that there is a grade B evidence with moderate level of certainty. Next, we'll look at the imaging studies to identify the SI joint pathology. And the question was posed as, can radiological images, including SPECT radiographs, CT, MRI, identify a painful sacroiliac joint and aid in distinguishing articular sacroiliac joint pain from painful dorsal ligaments? Now, we looked at the images. What images can we do when we actually have SI joint pathology, or at least when we suspect that? We can do radiographs, we can do CT, which can identify bone sclerosis or erosions. We can do MRI, and we can do CT and SPECT CT. Identification of the painful SI joint by imaging, therefore, we can actually conclude that it can be done by radionuclide bone scan, MRI, CT, and SPECT. And then if we pose a question, can we differentiate SI joint from painful dorsal ligament by imaging, there is no studies found. So this is what the criteria and what the conclusion were after examining the evidence, that the sensitivity of radionuclide bone scan is about 46%, but it is inadequate to identify the painful SI joint. Specificity may be higher, though, so we assigned it grade D evidence and moderate level of certainty. In terms of CT, has inadequate sensitivity and specificity, just low in both of those numbers for identifying SI joint. Therefore, we assigned grade D evidence with low level of certainty. The use of the MRI to identify the pathology in SI joint, it was counted as insignificant evidence because there are not very many studies to look for this particular element. In terms of SPECT and CT, there is great insufficient evidence to use it as a diagnostic tool. Thinking about it's very, very invasive as well. So the next, we're looking at the injections for the SI joint. Are intra-articular sacroiliac joint injections and sacroiliac branch injections diagnostic or prognostic? So if you think about it, we inject SI joints, we do sacral lateral branches blocks. Are those diagnostic or prognostic for identifying pain coming from the SI joint? So diagnostic, prognostic for SI joint, and diagnostic, prognostic for sacral lateral branches blocks. What we found that intra-articular SI joint injections are diagnostically valid for SI joint mediated pain, and we assigned grade B moderate level of certainty, with multiple systematic reviews partially support this injections. The intra-articular SI joint injections, unreliable prognostic for the RFA of the lateral branch of sacral lateral branches with grade C low level of certainty. In terms of if the sacroiliac branches to be diagnostic for pain arising from interosseous dorsal sacroiliac ligament and inferior dorsal SI joint, we assigned grade B, low to moderate level of certainty. And then there is insufficient evidence to assess the relative prognostic validity of sacroiliac branch blocks compared with other selection criteria for RFA, which is assigned grade I. In terms of performance, how accurate can you use anatomic landmark, ultrasound, and CT scan for obtaining intraarticular spread during sacroiliac joint injection? So we as pain physicians, we do primarily under fluoroscopy, but our interventional radiology colleagues, we do it under CAT scan. Some physiatrists are doing on the ultrasound. So how accurate is to do this, and based on what we know? So landmark and SI joint injections, palpation of how do you do it? Palpation of the posterior superior iliac spine. It's low accuracy for intraarticular. Fluoroscopic guided SIJ are basically more than 90% of injections we do to identify the pathology coming from there. Ultrasound guided SIJ. I think Dr. Cohen is going to talk a little bit more about it down the road. We did, the results were no difference in the pain scores and ODI and CT. The randomized, non-randomized retrospective analysis, some favorable studies for CT scan, but think about it, how much radiation those patients would have. So in terms of statements, what we identify the statement to be, the people which are suspected intraarticular SI joint pathology, accuracy of intraarticular spread is greater with fluoroscopically guided SI joint injections comparing with the landmark. And this is assigned grade B evidence, modern level of certainty. The one which is very clear is that SI joint injections should be done with images. Doing without images, it doesn't give you any value as opposed to images. So this we assigned a grade A recommendation with high level of certainty. And then the use of image guided should be strongly considered when performing SI joint injections, no matter what that would be the image. Grade B recommendation, high level of certainty. So in ultrasound can be used in some of those cases when the fluoroscopy cannot be used, and then that is grade C, evidence model level of certainty. Additionally, the ultrasound-guided injections, if you decide to do them, it depends specifically by the experience of the proceduralist. So we assign grade C, low level of evidence. And low dose CT guidance can be used sometimes by our if we think that we need to overcome some anatomical structures, such as with degenerative changes in SI joint, and that was assigned grade C, low level of evidence. And this is, in a summary, what we discussed about. So if you can see, I summarize pretty much for you what are the evidence and certainty. But in principle, for my portion of the talk, about a third back pain is related to the SI joint. History and physical examination may be useful to diagnose SI joint pain. There is no specific diagnostic test which we can actually use 100% to be reliable. Intraarticular SI joint injection should be performed under image guidance all the time. And I thank you very much. And I think our next speaker would be Dr. Cohen, right?
My slides are not here. Yeah, how do I have to go? Okay. Show moderator? Like this? There it is. I got it. Yeah. Thank you. See if it opens though. Yeah, but it's not opening. There it goes. Okay. So sorry that we're all kind of going through this quickly, but as Dr. Anatescu said, it's like a huge document, and so we're trying to just kind of provide the highlights. And so my section is on non-surgical treatments for SI joint pain, and so how effective are they? So common conservative treatments, right? We all, they're widely used, right? We can use medications, we use physical modalities, different, belts, psychological treatments. These are widely used, but the truth is there's actually limited evidence to support their use. So why is their use so common? CMS and payers kind of require that we try these things before we do specific interventions. And so CMS in particular says at least 4 weeks of conservative care before you can actually, do an SI joint intervention. And, presumably that if someone has acute pain, you would want to try, the least the most conservative things before doing more interventional treatments. And that they might help for some acute conditions. But usually by the time they're coming to pain clinics, they're usually more in the chronic stage, and so that's perhaps why they're more limited benefit. And one of Dr. Cohen's studies said that only 11% positive response after 3 months of conservative treatment. So again, there's generally limited evidence. So some of the more specifics in terms of physical, and I should mention that all these really are not studied specifically for SI joint pain, but rather they're studied in low back pain, and there's no really direct studies looking specifically at SI joint pain and using these modalities. But you can see in general that most of them have generally grade C and indirect, weak or low quality evidence. Combined CBT and PT. Actually, I italicized that one because it's grade B, but that's grade B and showing that it did not prevent the transition from acute to chronic pain. But as you can see, most of these are not indicated, particularly the chronic use of opioids. And so in summary, for medications and physical modalities, conservative care is often required, but is not actually proven. Conservative treatments lack direct evidence for SI joint pain. Some benefits maybe with NSAIDs, duloxetine, other SNRIs, physical and CBT for select patients, and that opioids are not recommended for chronic use. So what is the evidence for non-steroidal injections? So, obviously using steroids is the most common, but these are often provide short-lived benefit and may pose risks. So other agents, have been considered to be injected into the SI joints, in intra-articular, extra-articular. Regenerative agents are used because they could promote healing and mediate the inflammatory response. And so these are bioactive agents that are either naturally occurring, like PRP, or extracellular components like hyaluronic acid, Wharton's jelly, and then or irritating and debriding agents like saline, prolotherapy, and then other agents that could potentially be used or have been used are neural tissue targets that interrupt nociception, such as Botox or phenol. And so there are really no randomized sham-controlled trials for any of these injectables. There were some pragmatic RCTs for some of them, but overall, for most of them, these show insufficient evidence to recommend their use. Dextrose prolotherapy did show some evidence at 6-month evaluation, but this was grade C, low level of evidence. And PRP, some evidence at 3 months, but again, grade C, low level of evidence. So what is the evidence for cryoablation? So cryo interrupts the pain signal transmission. It's using extreme cold to produce nerve injury. Why could this potentially be beneficial over RFA? It could potentially make a larger lesion. There's less procedural pain, and there's also potential for nerve regeneration. But the evidence, again, is somewhat limited. There was really just a retrospective study and a case series, which you can see there. But in summary, there was insufficient evidence, and that randomized controlled trials are needed before further recommendations can be made. So is sacrolateral branch radiofrequency ablation effective? So it targets, RFA of the lateral branches target the posterior sacral network. This could include L5 to the S1 to S4 lateral branches. Why does radiofrequency work? Is because it disrupts the extraarticular structures, the nociceptive signals to that posterior SI joint complex. And the technique has advanced. As we're learning more about this posterior sacral network, we're learning which better targets. And so in terms of the validated techniques, Dr. Provenzano is going to go more into the specifics of this. But in general, when validated techniques are used, that there does show some effectiveness. And so there are a lot of studies out there that actually include non-anatomically validated techniques, and that impacts the outcomes. And so lateral branch radiofrequency is effective for SI joint complex pain for at least 3 months. That's grade B, moderate level of certainty. And when you exclude those ones that are non-anatomically targeted, that you can actually see pain sustained up to 6 months. So what are cutoffs for SI joint procedures? So overview, lateral branch blocks are often used prognostically before performing lateral branch radiofrequency ablation. Again, SI joint injections themselves can be either intra-articular, and they can be diagnostic or prognostic, or they could be therapeutic. And kind of the purpose of an injection sometimes kind of determines the relief threshold. So RFA trials use both 50% and higher thresholds, showed similar outcomes. A study by Dr. Cohen found that there was no differences in outcomes when using 50% or 80% thresholds, and that greater than 50% cutoff is then recommended for prognostic lateral branch blocks or SI joint injections. If you use 50% relief to define a positive diagnostic or prognostic block before, that's the grade B, moderate level of certainty. But then for therapeutic outcomes, using a greater than 2-point difference or 30% reduction, it should generally be defined as what's considered positive, with supporting metrics like quality of life, improved function, and satisfaction. And that's grade B, moderate level of certainty. So who are the best candidates for injections? So proper diagnosis is essential. The SI joint dysfunction accounts for 15 to 35% of mechanical low back pain, as Dr. Ernesto told you. And then diagnostic methods, physical exam, prognostic, lateral branch block, conformity injections are all things to consider when making the diagnosis. But in general, multi-site, multi-depth lateral branch blocks improve the diagnostic accuracy. Single-site depth blocks might not be capable of capturing all the innervation. Dual blocks do reduce false positives, but doesn't necessarily guarantee improved outcomes. And so patient characteristics that are influencing the outcomes. So poorer outcomes are associated with older age, so patients greater than 65. And this for radiofrequency ablation might be because patients who are older probably might have more of an intra-articular source of their pain versus extra-articular, which denervation is more likely to be targeting. Patients with higher baseline pain, longer duration of pain, opioid use, right? These are things that are similar to all other studies usually involved with chronic pain and interventional treatments. Additionally, psychological factors, depression, catastrophizing, sleep dysfunction would all be potentially associated with poor outcomes. So better responders, younger, opiate naive, and shorter duration of symptoms. So in summary, no standalone predictors of who's going to respond the best. And we talked about in terms of the patient characteristics, although these are grade C, lower level of certainty. Negative predictors also are anterior intra-articular pain, as opposed to the extra-articular sources of pain. And evidence does support prognostic lateral branch blocks versus intra-articular injections as the best ways to select for candidates for radiofrequency ablation, although this was grade C, low level of certainty. So what are complications? It's lateral branch radiofrequency can be effective, but it can be associated with complications, and you need to perform it safely. So complications can include local increased pain, paresthesias, hematoma. Rare theoretical complications are rectal perforation or sacral plexus nerve injury. And data on these usually come from rare instances of case reports. So what can you do to help? NSAIDs might help reduce post-op neuritis. This is weak evidence. Steroids and membrane stabilizers really lack strong evidence. This is grade I, insufficient. Anticoagulants typically can be used safely when performing these procedures. It is always safe, generally thought to be safe to perform bipolar RFA if someone has implants or hardware in the area. And motor stimulation may help avoid injury, although the use of sensory stimulation is limited. So in summary, non-surgical SI joint pain spans from conservative treatment to targeted injections and radiofrequency ablation. Radiofrequency ablation does offer some potential benefit in terms of positive outcomes.
Dave and I weren't sure who would go next. Let's see. Back, these are two. Okay, great. Thank you for being here. I'm Stephen Cohen. These are my disclosures. I guess the relevant one is that Avanos makes radiofrequency equipment. I'm not discussing that here. And, this talk kind of focuses on intra and extra-articular understanding that both components can be sources of pain. They can exist simultaneously. Understand who is more likely to have intra versus extra-articular, and be familiar with reasons to avoid the routine use of sedation, which may undermine the prognostic and diagnostic value. So the SI joint complex is a combination a fibrous joint and a synovial joint, infero-anteriorly. And pain from the SI joint can arise from a bunch of muscles, from a whole plethora of different posterior ligaments and anterior ligaments as well, and bone, the synovial lining, and the capsule itself. It's amphiarthrodial. It's designed for stability. It transmits, the weight from the trunk to the lower extremities, and all of these are imbued with, nociceptors, the capsule more than the ligaments. And you can tell when you're doing an injection and you approach the ligaments, people say, "Ouch, it hurts," because they have a higher density. This is kind of a rough breakdown, and a lot of these occur simultaneously, right? So the most common causes of intra-articular SI joint would be arthritis. It could be inflammatory arthritis, like spondyloarthropathy, osteoarthritis, infection, trauma. So these people are more likely to be older. They're more likely to have, at least later on, more advanced stages, bilateral pain. They'll have radiological evidence of degeneration, and they often have other arthritic pain sources. But again, these often occur together, and you could see this from one of the best trials for periarticular, right? A randomized placebo-controlled trial looked at extra-articular injections in patients with inflammatory arthritis. Extra-articular, you can have, ligamentous injury, myofascial pain, pain coming from the tendinous ligamentous insertions into bone, pregnancy because of the secretion of relaxin, because of trauma, because of the weight gain and the exaggerated lordotic posture. So these are more likely younger people. They have prominent tenderness. They're more likely to have unilateral pain, especially after an inciting event. They can have normal imaging, and they're more likely to get better over time, even without treatment. And has been gone over, the sacrolateral branches innervate really the posterior ligaments and probably the posterior bone. Like I say, these are pictures, intra, extra articular. The capacity of the joint is probably around 2.4, 2.5. It's a little bit actually greater in people with degenerative conditions. This is somebody with intra-articular pain, the picture on the right, somebody with extra-articular pain. The sacral degeneration lags a little bit behind iliac degeneration. So this is a question that I've been interested. The first study that looked at this, I reviewed this for the journal. It was a retrospective study. 40 people got intra-articular, 80 people got combination intra and extra-articular. They used the same dose of steroid, but the volume of local anesthetic was higher. And no group did incredibly well, but the outcomes definitely favored the combination group. Tintawi and Nazem did a randomized controlled trial. They compared intra-articular to combination injections. They again used the same steroid dose, and the combination group was better than the intra-articular group at 1 and 6 months, but not right after the injection. This is a group, the same group from Japan. The studies were separated by about a decade. The first study, they used hypertonic saline, and when it evoked pain, then they injected very, very small aliquots of lidocaine. The only outcome was, pain almost immediately after the injection. And I would say, I have a little bit of a problem with this because every single person got better who got extra-articular injections. I think that's a red flag. And they did another study, and they basically did something very similar. They used evoked pain, and then they injected small volumes like 0.2 cc's of lidocaine. Those who failed to obtain over 70% then got intra-articular injections. And again, the periarticular or the extra-articular injections did much better. So same group. This is a study that's kind of hard to understand. So this was quasi-randomized. These were people who had bilateral injections. They compared left-sided periarticular injections to right-sided intra-articular injections. They had 3 cc's. They used steroid mixed with lidocaine. These people all had severe pain, at least 8 over 10. And the periarticular injections were more effective immediately and at all time points through 3 months. And it was hard to figure out, as you can see here, like exactly what they did. This study is very underpowered to determine even, I would say, non-inferiority. What they were trying to do was to see if ultrasound-guided injections were accurate, and ultrasound-guided injections were not very accurate. So 8 out of 20, so 40% were not intra-articular. They then went and they looked at the outcomes up to 1 month between the extra-articular injections and the intra, and they didn't find significant differences. Again, underpowered study. NACI, this is a retrospective study. It's large. It's 113 injections in 99 people. They used very, very small volumes, so this probably wouldn't really fill the extra-articular ligaments. Ligament injections are more than 1 millimeter. So they had radiologists separate the injections into peri and intra-articular. They measured pain like up to 10 minutes after the injections and 1 week, and they were equivalent. So no difference. And I'm biased, but I think this is the best study. This was a double-blind, randomized, control, federally funded study. It was 125, patients, and they were randomized to getting fluoroscopically guided injections. Everybody had the most tender area marked. An envelope was opened at the time, and then if it said landmark guided, they just went into the landmark. Patients had, imaging of their other sacroiliac joint, so no one knew. So similar to other findings, very few injections when intra-articular. The immediate pain relief, so the diagnostic value was a little bit higher, 69% for intra and extra-articular, 62% for intra-articular, 57% for extra-articular. At 1 month, the outcomes were the same, and this is the sole study that found that at 3 months, some of the fluoroscopically guided and hence intra-articular injections did better on some outcome measures, not on secondary outcome measures. These are the graphs. So we found that there's a little bit stronger evidence for the efficacy of extra-articular than intra-articular SI injections for at least 1 month, but not for longer. So this is not saying they're better, just that the evidence was stronger that they're effective. So the next thing is something that I'm also very interested in, and so this is a big thing. We just all came from the ASA pain committee meeting, and this was a big discussion, right? People are using sedation a lot. A lot of the procedures that we do have diagnostic, they have prognostic value. This includes surgery, radiofrequency ablation, pulsed radiofrequency. Sedation increases the risk of the procedures. It increases the risk of a serious adverse event. It increased costs dramatically. And, in the most recent LMS, CMS said we're not going to routinely, pay for this. And Lynn has done one of, many studies. I mean, people routinely use sedation even for simple procedures. We know that opioids can reduce pain, but benzodiazepines can also reduce pain, right? It reduces muscle pain. They're certainly probably equivalent to non-benzodiazepine muscle relaxants in the upcoming FDA guidelines. We're not going to recommend them, not because they don't work as well, but because they have higher risks. They also reduce anxiety, and then people don't engage in their normal activities, which is important to tell if a block is successful. So this is from the same group. So the first one by Cucuzella was a survey study in 500 patients. They underwent epidural or facet injections. They were given low dose of diazepam. 17% requested sedation before the first. Then 28% of those said that they would want it before a second. If you had high pain scores, you were very anxious, it predicted the need for sedation. Then again, this study was done by the same group in the next year. This was a little bit over 300 people. They discussed whether or not they wanted oral or IV sedation. More than half the people chose to be sedated. Again, these were more anxious people. If you did get sedation with diazepam, it was successful at controlling it. And I won't go into the conclusions, but they said, sedation is not routinely required. I will say that I know, Dr. Kim, because she used to be active duty at Walter Reed. These are a physiatry-based practice, so they don't routinely sedate people. This is why you need a randomized trial. So if you just look at this data from Cucuzella, people who are sedated have more pain during the procedure. But that's obviously, you probably wouldn't see this in a randomized trial. It's because people who don't have a good tolerance to pain, maybe they have low pain thresholds, they're very anxious, request sedation. I was involved in all of these studies. So Paul Dreyfus, we looked at light sedation versus no sedation. There was no difference in immediate leg or back pain. This is Mike Erdick. These are people we looked at people who got sedation or no sedation before a celiac plexus block. And the people who were sedated, and they only proceeded to neurolysis if they had more than 50% or more pain relief, the people who were sedated did worse. This is a thing that we just did with Christelle Salmon. The reviewers requested this information. We didn't include it. And we were looking at the diagnostic, sympathetic blocks. Are they positive? Do you have sympathetically maintained pain, or do you have sympathetically independent pain? And if you were sedated, it was 0.051. You were a little bit more likely to have a positive block. And finally, Ian Chen, a colleague who's not here, we did a study with 265 and actually found that sedation during genicular nerve blocks was not associated with radiofrequency ablation outcomes. So this is the big randomized trial. This was a crossover trial. We looked at sedation during sacroiliac joint injections and sympathetic blocks because people were more likely to get multiple blocks. At the time, we were never required to have more than one facet block, and so we didn't do it. There were omnibus, so all sedation versus all not sedation, crossover and parallel group. And they all showed a higher percentage of positive blocks when people were sedated. but there was no difference in satisfaction or 1-month pain treatment. And then I brought this up in the pain thing. If you think that just using just a smaller amount of sedation or just midazolam is more likely to not result in a higher positive rate, we actually showed the opposite. Using just lower amounts is not going to prevent the increased positive rate. So no matter how you looked at it, right, sedation was associated with a higher diagnostic rate. So based on pain diaries, didn't matter if you received sacroiliac joint injections or sympathetic blocks. Again, there were no difference in satisfaction, and we found, as you would expect, that the good thing about sedation is they had less pain during the procedure. Guidelines, all guidelines, the ASA, we were talking about this, but also ASRA guidelines, IPSIS, they're fact finders. Sedation is not routinely required, and it will no longer be routinely covered. More on that. So, for diagnostic and prognostic injections, sedation is not recommended. Grade B, moderate to low level of certainty. For therapeutic SI joint injections, sedation is not routinely recommended, and the circumstances would be people with like an active, poorly controlled psychiatric problem, movement disorders, vasovagal. For lateral branch radiofrequency sedation, it might be necessary, but again, people don't really require monitored anesthetic care. So, in summary, the prevalence of intra and extra-articular sources of SI joint pain are comparable, and the evidence is at least as strong for extra-articular injections as it is for intra-articular. Younger people, those with pain after an inciting traumatic event, are more likely to suffer from extra-articular sources of pain. They can occur simultaneously. Combination injections might do better. All studies that looked at that found it. Sedation may undermine the diagnostic and prognostic value of all types of sacroiliac joint blocks, and they're not generally necessary. It may be indicated before radiofrequency ablation. Thank you. I don't want to mess you up, Dave. Okay.
Hello, I'm Dave Provenzano. I'm from Pittsburgh, Pennsylvania. I'll be talking about surgical techniques for sacroiliac joint pain. These are my conflicts. I have done research and have had consulting agreements. So the objective of today's talk is to identify the innervation, explain the various surgical techniques, including radiofrequency ablation. I'll go into that a little bit more. Also discussing some of the posterior fusion, lateral fusion, and open fusion techniques. Discuss factors that may influence fusion outcomes, specifically for fusions. Evaluate a little bit of the biomechanics. Analyze the trends in Medicare reimbursement for SI joint fusion procedures. And summarize the safety profiles. Obviously, we have a short period of time here, so I can't go into all detail, and I refer you to the document. So sacroiliac joint radiofrequency ablation. It's already discussed how you would diagnose this. I think it's really important to understand patient selection, understanding the anatomy is critical, and then optimizing technical aspects, which I've spent a lot of my basic science research on with both monopolar and bipolar. Radiofrequency ablation is much more complicated than just placing a needle, turning it to 80 degrees Celsius, and heating for 90 seconds. It's much more complicated than when you look into it. And you also have to understand the importance of modeling. So when you see an ex vivo model, how well does that correlate to an in vivo finding? And so I would say after doing multiple ex vivo models provide you with suggestions, provide you with prognostic suggestions of what will happen in vivo, but you really do need the in vivo model to fully understand what happens. So we talked a little bit about before, but I'm going to go over it again, sacroiliac joint innervation. And when you look at this study published by Roberts in 2014, you can see actually in only one of the specimens was there any innervation from L5. Most of the innervation was the joint was from S1 through S3 with some innervation in one case from S4, but that again depends on the joint and also where the S4 foramen is compared to the most caudal aspect of the joint. You can see that these lateral branches are very small. So I would say, take a small needle, take a small lesion, and go after a small nerve. Not an easy procedure. So there was another good study published in 2018 by Roberts. It was an anatomical comparison of radiofrequency ablation techniques for sacroiliac joint pain. The objective was to compare percent of the lateral branches captured by current radiofrequency techniques. This study helped guide some of the suggestions in the current guidelines on techniques that should be utilized. There was 3 monopolar, 4 bipolar techniques, and then there was 17 versions. You can see the monopolar and bipolar techniques here. Obviously, an internally cooled electrode is a thermal lesion. It is a monopolar technique. You can see here lesion coverage comparison, bipolar versus monopolar. This is a confusing slide, but I will summarize it for you. So bipolar, when you look at the mean number of lateral branches captured in an anatomical comparison study, it was between 93.4 to 99.7%. 100% capture rate for all the lateral branches would be somewhere between 62 to 97%. With lateral branches not captured at S1, anywhere between 1.5 to 29%. When you looked at internally cooled electrode, your mean lateral branch percent captured was between 79 and 89%. The 100% capture rate, though, was less, and lateral branches not captured S1. These numbers are correct. That was lateral branches not captured S2 and S4 too, anywhere between 0 and close to 30%. And then you can see the numbers for conventional monopolar. So what you can summarize from this, based on an anatomical comparison study, that a bipolar technique would have the best capture rates with regards to the lateral branches. However, I'll get into that further. So if you look at the recommendations from the guidelines, you're going to predominantly target the S1 through S3 lateral branches. Target as close to the lateral foramina as possible, but you have to remember, if you get too close to the lateral foramina with a bipolar technique, you could affect the nerves within the foramen. That's grade A evidence, certainty's high. L5 dorsal ramus, considering cases of transitional anatomy or upper SI joint pain, evidence B, moderate level of certainty. S4 lateral branch, you're going to target this when the foramen is at or above the inferior SI joint margin. That's evidence B with moderate level of certainty. Now, in an anatomic study, it was shown that bipolar is a good technique. I'm fascinated by bipolar techniques, but it's very complicated to get a really good bipolar lesion. It's not that easy as putting 2 needles down. Eric Kosman published a paper, I don't think that gets enough credit or focus, and if you look at all the variables involved in SI joint, bipolar radiofrequency ablation, it is highly complex. It's much more complex than just placing 2 needles. So you have to remember, when you have this is from one of my articles in 2014 when I wrote an editorial to one of Ricardo Vallejo's studies, but when you're looking at a bipolar technique, you have to think of a few factors. You have Y max, which is the maximum height of the lesion. You have Y min, which is the minimum height of the lesion. You have the interarticular electrode distance, which you set, and then you obviously have the depth of the lesion, which you care about with regards to the foramen. The reality is, if you have a lesion that has a very small Y min, you may never capture the lateral branch. It could be on the base of the sacrum and you may not capture it. So when you're doing a bipolar lesion, you have to think about your active tips. I would encourage you to look at that paper published by Eric Kosman. You have to look at the size and the length. You also have to think about what you inject. We published a study in RAPM in the mid-2000s looking at what happens to when you inject fluid, certain concentrations of saline, local anesthetic, that all modifies lesion size. You have to think about your intra-articular electrode distance. And also, when you think about intra-articular electrode distance, the most current recommendations are you would not separate the electrodes by about 10 millimeters. However, when you look at that, the reality is that your distance at the skin doesn't always reflect what the needles are doing at the SI joint. They can splay. And you also have to be very careful. Remember, the sacrum is not just a flat surface, so you get tip angle offset and angle skew. All these make a bipolar lesion very hard to get a great lesion. That's the challenge of bipolar RFA. You have to understand radiofrequency to optimize it. Again, I don't have time to go through it, but you have to look at the time setting, the tip size, what you're injecting if you really want a good bipolar lesion. This was an article that we published in 2024. looking at ways to optimize radiofrequency ablation using electrophysiological principles. We do talk about bipolar. I recommend you read it. So in technique, this was discussed previously, but to go over it, with an anatomically valid technique, which is monopolar cooled radiofrequency ablation or bipolar strip lesions targeting S1 to S3, plus or minus L5 and S4, you can hope for greater than or equal to 6 months improvement in pain and disability. This is evidence grade B, certainty moderate. If you use an invalid technique, evidence grade C, moderate, certainty level of low. And then when you're doing these techniques, obviously you want broader lesions and larger volumes to accommodate anatomical variation. And that's to improve coverage. And this is a grade B recommendation, evidence with a moderate certainty. When you're selecting people for fusion, now we're talking about a fusion, you want greater than 3 out of 6 positive provocative tests. You want to diagnose SI joint pain, which the recommendation in the guidelines is to use local anesthetic interarticular blocks with greater than 50% pain relief without steroids. You want to have ruled out other disorders, also with radiology, and you want to have a failure of non-operative treatment. It's a shame to me that we have trouble getting covered RFA before someone goes to a fusion. I mean, fusion is not without consequences. I think the spine surgeons can teach us that. So there's multiple ways you can do a fusion. You can do it posteriorly, minimally invasively. You can do it laterally. You can also look at open SI joint fusion. So there's really 3 scenarios, but it gets more complicated. There's open, minimally invasive posterior, minimally invasive lateral. And then when you look at the codes like 27278 and 27279, there's a difference whether in the minimally invasive techniques you transfix the joint. So we talked about predictors that are poor for other procedures in the SI joint. Same thing with the SI fusion. If you smoke, you're going to have lower improvement. If you have opioid use, lower patient age of interest, and lower duration of SI joint pain. These are predictors for reduced improvement in outcomes. I think it's really important if we're going to do fusion techniques, we have to understand what we're doing to the joint. We also have to understand the collateral damage that it's having on the rest of the spine with regards to mobility. Lateral and posterior approach, when you look at literature review of 55 studies, have similar stability. And when you look at unilateral versus bilateral stabilizations, both have significant decreases of range of motion. So if you don't think insurers are going to look at this and you don't think Medicare is going to look at this, this slide is very interesting. This is procedures done for SI fusion. This is from 2015 to 2020. And you can see that the total number of cases increased by 592%. You can see that minimally invasive, 52% of the procedures were performed by non-surgeons. Obviously, 71% of the open fusions were performed by surgeons. This is just a 2020. So you can see that this is like astronomically growing. So is there a lot more people with SI fusion pain? SI joint pain that need fusions? I'm not sure. But it's concerning. So when you look at the guidelines, there was moderate evidence for the open approach and the posterior approach, grade C, with regards to fusion techniques. When it came to the lateral approach, the statement was that there's mixed evidence. And why is that? That's because the Rander study, which I give them credit for, from 2024, was a shammed, double-blind, randomized controlled study that compared sham SI fusion to SI fusion with the lateral approach. In the sham group, you took a guide wire and you put it through the muscle and you went down to the ilium. But the reality is that there was no difference at 6 months between those two procedures for the lateral approach. Obviously, this made some people not happy, but when you looked at mean numerical rating scale at the operated sacroiliac joint compared to SAM to fusion, and you looked at baseline and the 6-month outcomes, the fusion group went from 7.6 to 5, and the sham group went from 7.7 to 6. The mean difference was -1. When you looked at the confidence interval, part of the confidence interval did cross over 0, but so you would say here that with the lateral approach, there was not a big difference between sham. When you look at additional surgery following SI joint fusions, this is a retrospective analysis of almost 280 patients. So 66% had had previous spine surgery prior to undergoing a fusion. After the fusion, 43% required additional spine or joint surgery after the fusion. Of that, the contralateral side was 54% of those surgeries. This was a literature review of 819 SI joint fusions. There was 91 complications with a complication rate of 11. Most common complication was wound infection, drainage, nerve root impingement, and trochanteric bursitis. I think anyone that does a lateral approach, though, you have to be very careful because you can get the inferior gluteal artery, which can result in significant bleeding. And so if you're in an ASC and you don't have the capability of handling inferior gluteal artery bleeds, I think you have to be very careful with the lateral approach. So does minimally invasive surgery to the SI joint save money? This was a study published in 2014, and there was basically two groups they looked at. One was without lumbar spinal fusion, and one was with lumbar spinal fusion. You can see with lumbar spinal fusion that the cost, you saved money at about 1 year, but without lumbar spinal fusion, that it took about 6 years before there was cost neutrality. So in conclusion, I think sacroiliac joint surgery may be appropriate for a certain small subset of people. Understand the different approaches with regards to open, lateral, and posterior approach. There is currently a study for the lateral approach that it was no better than sham. That's just one study, though. You have to understand your anatomy for both lateral, for radiofrequency ablation, for the lateral branches. You have to understand how to optimize technique. Obviously, we should use minimally invasive methods that are safe and effective. Personally, I think you should have an ablation prior to a fusion. And I think we should continue to gather more data on cost effectiveness and continue to understand the biomechanical impacts if we're going to do fusion techniques. Thank you.